Well, hello everyone. Hi. We're gonna start soon. So this week's topic is on neurons by popular demand, and we're going to be looking at the functional anatomy and the anatomy of the neuron itself, and then within the different pathways and how that affects and is changed in disease. So going through the contents, we're going to be looking first at neurons themselves, so the different axon types. This is going to be primarily about the sensory neurons and sensory nerves. We're going to talk about the ascending pathways, so that's the sensory pathway, so dorsal column, medial lemniscus pathway, the spinothalamic pathway. We'll also talk about the descending pathway, so this is your motor pathways, corticospinal and corticobulbar. Those are the two ones we'll be talking about. And finally, we'll also have a look at the autonomic pathways. As always, we'll have sample questions, and that'll be question and answer time. So, first things first, this is a neuron. We've all seen this picture before. It's comprised of dendrites, cell body, axon, which is in between, and all these myelin sheaths. In the peripheral nerve, you have Schwann cells, and in the central nervous system, you have oligodendrocytes. So they have axon terminals, and this is the direction of the impulse. You have the soma, which is the cell body and the nucleus. The dendrites interact with other dendrites so that they can synapse and create signals, and axon terminals move and join with other dendrites or onto tissue. This is a microscopy picture here. So we have this is the Schwann cell. So this is the nucleus of the Schwann cell. This is a cross section. So if we were to cut across right through there, this is what we would see. So this is right there, the product of that. So what we have is the axon in the middle. As you can see, it's packed. It's with these little tubules. We have a myelin sheath, which is just, if we zoom into it really closely, it's just a lot of layers just wrapped around each other. And then we have a Schwann cell. We also have something called the neurolemma, which is the sheath of the Schwann cell, which surrounds the whole tissue. And it's the outermost layer of the nucleated cytoplasmic part of the Schwann cells. And it surrounds the axon and the neuron. And its function, it's protective. It's for to preserve the fibers of the nerves, and so that when the Schwann cells get damaged, the outer neural lemma gets damaged, the axon itself is not damaged, and therefore it can regenerate. And especially to maintain the cell body in good health, and so that it can regenerate. So it serves a protective function. So now we have different types of axons. So we have then A alpha. So this is the thickest axon type with a lot of myelination. It's high speed transmission. And the reason for that is because of these Schwann cells and these roads of Ranvier. They essentially help the signal to skip through the membrane to accelerate it. And it's a sensory receptor, and it's primarily used for proprioception of the skeletal muscle. So this is the balance. This is our ability to sort of visualize our position of our bodies, and especially the joints themselves. We have A beta, which is mechanoreceptors of the skin, less myelinated than the A alpha, so therefore a little slower. Then we have A delta and C fibers, and these are the fibers for nociception. And for nociception, we need higher threshold transmission, which means that the level to get pain is smaller. So these are usually polymodal, so they can be temperature, pain, or itch, and that's usually your C fibers, and there's also some mechanical pain for A delta fibers. Now that's for pain. You want high threshold because you want to have a high amount of pain before you get a signal. So pressure, you do not want pressure to be implied as pain. We have thermal, so we have stimulus. This is your warmth, heat. So this is your C fibers that do the warmth. whereas cold is A delta fibers. We also have mechanoreceptors, so they're low threshold, and that's usually your A beta fibers. They usually do the slow adapting for cold, and fast adapting mechanoreceptors are usually also different types of A beta fibers. But for pain, it's A delta and C fibers. So we're going to compare these two. So for A delta, the transmission for A delta is physiological. So this is usually pressure and like it's sharp and short and localized. And the thing is here that when you have this pain, this is physiological pain, it's high threshold, it's quick, it's sharp, and it lets you know, okay, you've pressed something that's bad, and it's like a response. Right? And the effects of this is that you have a reflex withdrawal, so you want to move quickly away. So this is like when you touch something warm and you go, or something cold and you go quickly away. That's A delta. Morphine does not abolish this pain because this is your short pain. This is not your chronic lasting pain. This is your short pain. And it's usually high threshold thermomechanoreceptors. Now for C fibers, they do pathological pathophysiological pain. So this is some chronic pain. This is when you have, let's say, some dull, diffuse, prolonged pain. Maybe it's cramps. Maybe it's inflammation in the abdomen or acute abdomen, and it's just this generalized pain. And this is where morphine works. This is your pain where the morphine works. And the effects of these C fibers is like, if you imagine the stomach, this is the perfect example, and you have sore, let's say for example someone has a gallbladder problem or an infected appendix or appendicitis, they will be sore all over their abdomen. And as a result, you will have muscle spasm and you'll have guarding. And guarding is when the muscle tenses up. When it tenses up is so that you do not propagate the pain. And morphine works really well on these. So C fibers, morphine abolished. A delta fibers, morphine does not abolish. So the next sort of big division is sensory versus motor. So sensory neurons usually have multiple neurons within their structures, usually 3 neurons. So you have your primary sensory neuron, which is from the periphery. That goes from the periphery and it connects to the central nervous system, usually the spinal cord or in the brain. And this travels up the tract of your spinal cord and it reaches the brain, reaches the thalamus, the VPL of the thalamus. We'll get to that. And from there you get the third neuron, which goes to the cerebral cortex into the primary somatosensory cortex or the postcentral gyrus. So, and your motor pathways, they're a little bit simpler. So you have an upper motor neuron and a lower motor neuron. And the upper motor neuron comes from your motor cortex and from the brain. It can go to cranial nerve nuclei, so that's a corticobulbar, or it can go all the way down through the spinal cord and into, so it's either the brainstem or into the spinal cord and act as synapse for lower motor neurons, which interact with muscles to give us movement. So sensory, it's usually 3 neurons, and motor, it's 2. So let's talk about some myelinated axon tracts. So we've talked briefly about this in the anatomy of the spinal cord. So this is just a quick overview. So in the dorsal aspect, so in the dorsal column, so this right here is the dorsal column. So this here, the dorsal column, is comprised of 2 parts. So you have gracilis, so it's fasciculus gracilis, which is a sensory fiber, and it's for the ipsilateral lower limb. So it's on the same side, lower limb. Whereas your cuneatus is for the upper limb. So this is the big differentiation between the two. If it passes through the gracilis, the origin is from the lower limb. If it passes through the cuneatus, which is a bit more lateral rather than medial, it's from the upper limb. And they have the same sort of function. It's your fine touch, vibration, proprioception. So these are your dorsal column pathways, or the posterior column pathways. We then have the spinothalamic thalamic tract, which is a bit more anteriorly and laterally, so it's this part here. And what this does is your pain, your temperatures, and it's from the contralateral side, so that means it will decussate on the other side, and we'll get back to that as well. So the spinothalamic and gracilis cuneatus is for your touch, vibration, and for your pain and temperature respectively. We also have something called the spinocerebral tract, which we'll cover very briefly here. And the spinocerebral tract, it's from the lateral part here, and it does the proprioception from the limbs to the cerebellum. So as we said before in our brain series, in our brain lecture, the cerebellum acts as a balance. It's coordinating movement. So this is where the fibers come from that. Motor, which I will do in a bluish color here. So we have the anterior corticospinal and the lateral corticospinal. And these are the 2 points because they decussate once again at the pyramidal tracts, and they split into 2. The vast majority decussate and a few minority do not decussate. The ones which are in the closer, so the ones which are in the anterior corticospinal tract, they usually do the innervation of the axial muscles. So if we remember from our embryology, it's because it's closer together, so that's the axial muscles. Whereas the lateral ones, it's because they're further away, they become the limb musculature most of the time. In the middle, we also have the anterior white commissure, which is where the pain and temperature fibers cross over. You also have the decussation of our corticospinal tracts. So this point is very important because it's where the fibers cross over. So summary, we have sensory, which is our dorsal column pathway. We have a spinothalamic, which are key main pain and touch pathways. We have some proprioception from limbs to the cerebellum, which is through the spinocerebral tract. Motor, we have corticospinal tract, which is anterior and lateral. This goes to the limbs, and corticobulbar, which goes to the brainstem via cranial nerve nuclei. Moving onwards. So what we have here is the dorsal column medial lemniscus pathway. And it's a very tricky pathway because it involves 3 key steps. So we start with the function. So we talked about its discriminative tactile touch. So this means light touch, vibration, and proprioception. It decussates at the brainstem, so it has to go up and decussates at the brainstem. And what it means by decussates is that it's supplied by the contralateral, so the contralateral side. So it decussates, so if it's the right side, you're feeling some innervation, then it goes to the left side of the brain. The fibers primarily for this are A beta and A delta. And the pathway is quite tricky. So we have the entry into the spinal cord. So we start here with a spinal cord. So it goes through the spinal ganglion. So we have that here. And it enters the posterior columns. And as we said, gracilis is the medial one. So if it's gracilis, it's going to be lower limb. If it's going to be cuneatus, it's going to be the upper limb. So they enter through there and they travel upwards. So if it's T6 and lower, so that's going to be your gracilis. And if it's T6 and above, that's going to be your cuneatus. Now, the decussation occurs at the nucleus gracilis. And this nucleus gracilis is found way up high within the medulla oblongata. So the medulla oblongata is where the primary, so this is the first neuron. So right here we have the first neuron. So that's the first neuron. Goes all the way at the point it lies in and travels to the medulla. So this is our medulla here. And that's called the nucleus gracilis and nucleus cuneatus, and they correspond to if it's upper or lower limb. Now the secondary fiber, so we have a secondary fiber here. That comes from and it decussates at the medulla oblongata. And this is called the inarcuate, internal arcuate fibers. It's right through here. So this decussation is the second, that's the second neuron. So the second neuron, it crosses over and goes through what's called the medial lemniscus. This is why it's called the dorsal column, because it originates in the dorsal column and moves up to the medial lemniscus. Now the travel of this is that it goes through the rostral medulla first. So they travel as medial lemniscus in the midline, and then they go slowly become more lateral. And once you sort of ascend through the pons and the midbrain, you eventually end up in the ventroposterior lateral nucleus of the thalamus. That's the VPL, so the ventral posterolateral nucleus of the thalamus. So that's our second neuron. And then our third neuron, I'll do this in red, our third neuron starts from the VPL and goes to the post-central gyrus. That's our third. That's number 3. And this, so when it goes through thalamus, it goes through the internal capsule and the corona radiata. So that's where it sort of fans out in the 2 directions. Now, as we can see, we started on the, like, let's say this is the right side, and we ended up on the left side. So this is because of the decussation at the medulla. So to summarize all of this, we have discriminative tactile sensation, decussates at the brainstem at the level of the medulla oblongata. First neuron is through the posterior column to the nucleus gracilis or cunatus. There we synapse with the second neuron, which crosses over from the medial lemniscus, through the medial lemniscus all the way to the ventroposterolateral nucleus of the thalamus, and then from there it goes to the primary somatosensory cortex in the postcentral gyrus. So this is meant to be the spinothalamic. I didn't label this properly. This is the spinothalamic. That's the spinothalamic tract here. And so the spinothalamic tract, the main function is pain, temperature, and itch. Axon types is your A delta and C types primarily. Now the pathway is very similar. It's still 3 neurons, but they go at different points. So the first neuron, once again through the spinal ganglion, you get some noxious stimulus, and it synapses at the the posterior dorsal horn. So this is where the first neuron ends. So this here is first neuron. That's the first neuron. The secondary neuron decussates. So that means it crosses over. So it decussates from here to the anterolateral spinothalamic tract. So it decussates. Crosses the anterior white commissure, and then it ascends all the way to the top. So that's our second right there. And essentially what happens, it goes through the anterolateral part of the tract, as we saw before, and it moves anteriorly and then laterally. So it goes anterior, laterally, and then posteriorly. In the caudal medulla, it goes up and up and up, and it goes in between the nucleus of the trigeminal nerve and the inferior olivary nucleus. That's just some intricate anatomy for you. But it lies sort of medial, so laterally to the medial lemniscus. This will be the medial lemniscus. It lies laterally to it. And eventually it terminates at the top here at the VPL, much like the previous pathway. So the previous final part this is the third neuron here. And that also goes to the somatosensory cortex, through the thalamus, through the internal capsule, through the corona radiata. So the pathway is very much the same. So it goes primary, spinal ganglion, it's at the dorsal part. We get a second neuron which synapses, and then it crosses over and it goes up, 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 all the way to the VPL, and then you have the third. So to summarize, pain, temperature, and itch. Decussation occurs at the spinal cord. Axon type is your A delta and C fibers. First neuron synapses at the dorsal horn. Secondary neuron crosses over to the midline, ascends all the way up to the VPL, and then from the thalamus you go to the post-central gyrus. And that's the spinothalamic tract. So that's our sensory tracts. Now we're going to talk about the motor. So it's going to be the corticospinal. And we're going to have it's a similar top-down view, but this time we go from the head all the way down. Now what happens is in that the function of this is from the primary motor cortex to do contractions of the muscle. So the cell bodies of these nerves lie in the primary motor cortex, and we have passage through something called so it descends through the internal capsule, the corona radiata, posterior limb of the thalamus, and then it goes all the way down through the basis pedunculi. Basis pedunculi is a part of the crus cerebra. It's roughly like 2/3 from here. So like if you can imagine this divided into thirds, it's right about here, 2/3 away from the anterior part, and it passes right through here. It's in the anterior midbrain. And then once it reaches the pons, so we have the midbrain, pons, medulla. Once it reaches the pons, it sort of splits into numerous fibers, into bundles. Now the decussation happens at the pyramids of the medulla. And 85%, so if you can think about it like this, 85% go on that opposite side. So 85 go this way, and 15 go in this direction. So 85 in this direction, 15 in the other. So they cross over, and we have the lateral tract, and then we have the anterior corticospinal tract. Now the termination is very similar, so they terminate in the lower motor neuron nuclei in the anterior horn of the spinal cord. So regardless, they all have to meet in the anterior sort of horns here. And the lateral corticospinal tract goes to the anterior horn here, and so does the anterior corticospinal tract. So the fibers cross the midline, and they go to the relevant areas to terminate with the relevant lower motor neurons. So the key decussation here is at the pyramids, once again at the medulla. It's called the pyramids because they look like pyramids, and they cross over. So to summarize all of this, they connect the lower motor neurons in the spinal cord to the brain. So without this, the motor neurons wouldn't be able to contract. They wouldn't know when to send signals. They wouldn't know what to do. So they're very important. And then we have the axon passage through the basis pedunculi, decussates in the pyramids, and they terminate on the lower motor neurons. Now the corticobulbar part is very similar. However, the end point for corticobulbar pathways is in the cranial nerve nuclei, which are found in the brainstem. So this goes to the spinal cord, that's called the corticospinal. Brainstem is corticobulbar. So that's our somatosensory and motor pathways. If anyone has any questions, feel free to leave them in the chat. And yes, so we're going to talk about the autonomic pathway. I will answer the questions as they go. So the autonomic pathway, we have our sympathetic and parasympathetic. Right. Sympathetic and parasympathetic. There we go. So the sympathetic and parasympathetic has, two different parts, and they act on similar organs, so it can become quite confusing. But I'm here to try to make that a little bit simpler. So the sympathetic, if we think about a sympathetic, it's an accelerator, right? It's like, let's go, right? It's fight or flight. So that means increased heart rate, decreased gut motility. That means we need to be alert. So that's pupil dilatation, so we see more, and bronchodilation, so we can breathe more. Whereas the parasympathetic, we have to think about us as a brake. So it's the brake in the body rather than the accelerator. And that's our rest and digest, feed and breathe, pupil constriction, vasodilation, mucous membranes, and all that stuff. It's to decrease the heart rate and increase gut motility. Sorry about that. Check. Anyway, moving onwards. So there's two different types. We have the neurons, and then we have the ganglia. And they move in two different ways. So we start with, in the thoracolumbar region, we have this thing called the sympathetic chain for the sympathetic part. That's absent in the parasympathetic. Essentially what this does is that we have connections from the nerve roots to the sympathetic chain, and then they go to the preassigned areas. Whereas in the parasympathetic, you have these really long nerves which start at the particular part, like the brainstem or the sacral nerves, and then they go to the desired area. So the sympathetic chain is much closer to the desired areas, and therefore the distance is shorter. Now, for the thoracolumbar, it starts from T1 to L3, whereas for the brainstem we have 3, 7, 9, and 10, right? So it's 3, 7, 9, and 10. And we also have the sacral regions S2 to S4. So the location of the ganglia, they origin from T1, it's quite close to the areas, whereas here the ganglia are right next to the target of the viscera. So they have long neurons, and then you have a really small ganglion, which is really close. Whereas here we have the ganglion in the sympathetic, which is quite long. It's close to the spinal cord itself, and then you have these long fibers afterwards. Now, as a result of that, we have short preganglionic neurons, as we can see here, and long postganglionic. Whereas in the parasympathetic, it's the reverse. We have the long nerve, so think of vagus nerve, really long nerve. We have the vagus nerve, cranial nerve 10, and it goes all from the lungs to the stomach, to the heart, to the intestines. So it's very long. The postganglionic is very short because it's close to the target organ. So we have cervical nerve 3 is close to the eyes, postganglion is close to salivary glands, it's very close to parts of the stomach, or even just directly goes there without any ganglions. So the nerves are bigger in the parasympathetic and longer before they reach a ganglion, whereas here they're short towards the ganglion and long from there. Now, the myelination is also a little bit different. So the preganglionic neurons are usually myelinated, but they're short, whereas the parasympathetic ones are also myelinated, but they're much longer, and both postganglionic ones are usually unmyelinated. They also have slightly different neurotransmitters. So for sympathetic, we have preganglionic, so this would be acetylcholine, and postganglionic is noradrenaline, whereas here it's acetylcholine for both pre and postganglionic. That's the key sort of difference between them. They also have slightly different receptors. So in the sympathetic, because it's adrenaline, you have noradrenergic receptors. So alpha 1 is for arterials, alpha 2 your coronary and venous constriction, beta 1 is for your heart, adrenal glands, and renal, beta 2 is for your lungs. And this is where all the different drugs come from as well. Whereas in parasympathetic, you have muscarinic, which is for smooth muscle, and nicotinic, which is for motor end plates. And to summarize, this is basically a summary picture here of the differences between the two. So if you think about it, the key aspects here to know are the location, so it's where do they originate from, the lengths of the neurons, so always think vagus nerve is very long and it goes to the target area. Myelination is somewhat important. Neurotransmitters I would definitely remember, and most importantly the function. So sympathetic is an accelerator, fight or flight. It takes away nutrients from the gut and it goes towards the heart and the lungs so you can breathe into your muscles, whereas the parasympathetic is a brake and it does the opposite. So that's the first part. That's before we go into the questions and the sample questions. If anyone has any queries on what's been covered so far, just ask in the chat and I'll go over through them. So just type them into the live chat. So ask questions here, and I'll go through them. Okay. I mean, if you have questions as we go ahead, then just type them out. So I'll be just moving on here. So this is a typical question that we get. It's a labeling question. So we get histology, but also you would get some hand drawn. So it looks like what the histology is supposed to be, but it's hand drawn, something like this. And you'll be asked to label this. So number 1 is pretty clear. It's an axon. That's the centerpiece. Number 2, so this is the nucleus of the Schwann cell or the supporting cell. If they say it's a peripheral neuron, it's a Schwann cell. If it's a central nervous system neuron, it's a oligodendrocyte. Number 4, we have the myelin sheath here. Sorry, the myelin sheath is number 3 here. Number 4, we have the neurolemma. So the neurolemma would be the outermost layer right here, and number 4 would be the myelin sheath. And I got the answers here wrong, so these I just swapped out. So as I said before, the neurolemma is this outer region here. It encompasses everything. It protects both the Schwann cell and the myelin sheath, whereas here it's myelin layers. And the way these layers get spun is like you have your axon in the middle. So let's say that's your axon. And you have all these folds coming around. So it's literally folded like this. It's a spiral. Right? That's what that looks like. And if you zoom out or zoom in, sorry, you will see them like this. So when you see something like this, this is a picture. You should sort of picture in your mind a cross section of a neuron. So number 2, describe what is shown on the following slide. So what we see here is, so it's a Schwann cell. That's the Schwann cell here. We have an axon. There's a nucleus of some sort here, so it's probably in the neuron itself. But what are we seeing here? What is this part here? What are we seeing on this axon? Well, Schwann cells and oligodendrocytes can associate with axons, but not wrap around them and create axon and myelin sheaths. So what we see here is an electron microscope showing a Schwann cell here, which is not associated with myelinating axons. So it's all these small little axons, but they're not myelinated. So these fibers are quite close together. And this is very common. You might have a Schwann cell, but it does not attach to the axons. So if you were to see myelination, you would have a very dark ring around it. Very dark ring and several rings around it. So it would look like this. So that's how you know you have a myelin sheath. But here we have no myelin sheaths. We have some myelin sheaths right here. That's a myelin sheath there. But these ones, no myelin sheath. So this is unmyelinated. Whereas this one here is myelinated because it has some myelin sheaths. And we got a question like this in my year, and I found it super confusing. So here I'm explaining this so that you don't do the same mistake as I do. So once again, this is a labeling exercise. This is always comes up. It didn't come up in our exam, but it does tend to come up a lot. And it's basically, do you know the different layers of the spinal cord? So dorsal column, gracilis, which is for discriminative touch in the lower limbs, cuneatus, which is for discriminative tactile touch in the upper limb. C is your spinocerebral because it's a little bit lateral. D and F are your corticospinal tracts. They are lateral and anterior respectively. E is your spinothalamic tract because it's an anterior part. Fibers cross over. So yeah, good question to know. So we have compare and contrast the corticospinal and corticobulbar tracts. Well, typical question. So this is the outflow. So you have the motor cortex. It goes through the basis pedunculi, goes through the tracts. So we have midbrain, pons, medulla. It decussates, so 85% decussate on this side, 15% continue downwards, and then eventually go to the relevant side anyway. And both, so the difference between the two is that they both look similar. Both have this passing through the pyramids and the decussation, but the corticospinal goes to the spinal cord and their nuclei and connects with lower motor neurons, whereas corticobulbar goes from the brainstem cranial nerve nuclei. And so keep this in mind when you're learning. It's very similar to one previously. What will happen here is that at the point where it becomes outwards to facilitate motor transform and to also have synapses with lower motor neurons, the nerve will come like this, and this nerve will come here, and you will have your synapses with your lower motor neurons. So the answer for this would be compare and contrast. So both are descending, both pass pedunculi, decussate the medulla, but spinal goes to spinal cord, bulbar goes to the bulbs of the brainstem cranial nerve nuclei. So next question, what are the differences between an upper and lower motor neuron lesion? So the upper motor neuron lesion, so we have CNS damage to the brain, such as stroke or cancer or whatever, something damages the upper part. And therefore, this means that we have either in the brain or in the spinal cord, we have a problem. So the signaling here is not as good as it was before. And this could be also lesions of the motor nerve, like motor nuclei of cranial nerves or neural pathway from the anterior horn to the spinal cord. And what happens here is that the damage occurs, and therefore you're not getting regular signaling. And all the signaling comes from the lower motor neuron. And what this means is that you don't have as much control. So think about this, the brain is more developed. It asserts more control over the body. The lower motor neuron is primitive, right? It just goes from point A, so from the spinal cord to the muscle, and its only job is to tell it to contract. Now, the upper motor neurons, they regulate everything. And this will become very important when we talk about the different features. So when we have an upper motor neuron lesion, we'll have something like muscle weakness, right? We'll have increased tone and increased reflexes. Now that doesn't really make sense. How can you have muscle weakness but increased reflexes? Well, the reflexes, they do not go to the upper motor neuron. The reflexes are local. So the reflexes will come from here and they go directly to the spinal nerve root or the segment of the spinal cord and then go back down. And the reason it's a reflex is because having the ascending pathway go all the way to the brain and all the way back down takes too long, right? So like, let's say there's something warm, something sharp. By the time your brain processes everything, it'll be too late. You'll get burnt, right? So that would be a useless reflex. So the reflex is an adaptation for us so that we can react immediately and quickly. And the reason why the upper motor neurons, when they're not working, we have increased reflexes, is because they're not there to tone down the lower motor neuron lesions, or the lower motor neurons. So that's what the next part of the questions. What are the features of upper motor neuron lesions? So it's muscle weakness, increased tone, and increased reflexes. Now, conversely, lower motor neuron lesions, well, you have muscle weakness plus wasting. So why is there wasting? Well, it's because there's no way to activate those muscles, right? Those muscles will not be activated anyway because the lower motor neuron here, this lower motor neuron, that's broken. This lower motor neuron maintains muscle tone, it maintains strength, so the muscle can still work, you just don't voluntarily control it. And you also have something called, so therefore you will have reduced reflexes because the motor neuron connecting it towards it was not working. You'll have fasciculations. So the fasciculations are basically, it happens normally as well. You can get like these muscle twitches. But they happen more commonly with lower motor neuron lesions because you have nothing supplying there. And it's the remnants or the local molecules and the local neurotransmitters and stimuli that causes the stimulation, which is not controlled. So when you have a lower motor neuron lesion, you'll have muscle wasting, reduced tone, and reduced reflexes. And I think the best way to sort of visualize this is to just draw it out. So let's say this is our upper motor neuron, right? So that's upper, and this is lower, and I would do this during the exam, even now. That's our lower. And if we cut out this, so if we say no more that, well, then we have nothing to tense the muscle. So this is our muscle here. We have nothing to tense the muscle. We have no way to exercise the muscle unless there's other nerves which can help the muscle. And we get fasciculations and reduced reflexes. Now, if we have no access here, well, then this nerve still works. We can get all our reflexes, and the upper part of the brain can't tone down the lower part of the brain. And therefore, we might have weakness but not wasting. We'll have increased tone because the nerve is constantly feeding its signals to sort of tighten up, and we'll have increased reflexes and no fasciculations. So yeah. And so this, and also back to fasciculations, it's a spontaneous muscle twitch. It's normal. Some patients might come in and say, oh, I have this twitch. It's normal. It can come with stress, you have fasciculations, but it's also caused by the increased receptor concentration on muscles that try to compensate for the lack of innervation. So it's an adaptation as well, these fasciculations, because the muscles want to be contracted, they want to be stimulated, and they see that there's no signal coming in, so they think, okay, we need more receptors to increase stimulation. But these receptors can be stimulated by other things, which causes your fasciculations. So now, a sort of overall look. So upper motor neuron lesions, we have muscle wasting, yes. Muscle wasting and lower motor neuron lesions, upper motor neuron lesions, no. Fasciculations, yes, not present here. Tone. So the tone would be flaccid. That means it will be weak, whereas this one here will be spastic. So flaccid means that it doesn't feel tense. The muscles feel weak. The muscles feel off. So if you were to touch them, they feel very gooey. You see this especially in elderly people. That's flaccid tone. A spastic tone will be when it's hyperextended, right? And that's because there's no upper control to release the tension from the lower motor neuron. So you'll have weakness on both sides, but you'll have weakness due to loss of muscle bulk, right? And you will have sort of paralysis or weakness due to an upper motor neuron lesion because there's a lack of motor neurons being recruited by the brain. Tendon jerk reflex will be reduced or absent, and we talked about that because the lower motor neuron is not doing its job. And here will be exaggerated, something called hyperreflexia. So Babinski response is when you have someone's foot and you run the pen up that foot or a stylus, and it will be negative here because you'll have normal toe flexion, so that's fine. But positive in the upper motor neuron because it's due to sort of extrinsic and extensor spasticity. So you'll have negative, so normal toe flexion, but positive in the upper motor neuron lesion. So moving onwards, we have what are the different features of spinal injuries at the following segments? A very common question. So this is applying the anatomy. So you learn about the anatomy, learn the different functions of the different segments. Now, how does that translate into injuries? So let's have a look. So we know that C1, C4 is responsible for, it's the neck, so that's your upper limbs. But if you think of a lesion, that means it also cuts down everything below that. So if you have a lesion here, that means all of this is gone, right? So that's how you have to think about it. So if you have a lesion in C1 to C4, well, you have dead to quadriplegic. But the phrenic nerve is also C3, C4, C3, 4, and 5. You know, keeps the diaphragm alive. That's the sort of acronym for that. So if you have C3 to C5, well, they won't be able to breathe either. So that's a big problem. So C5 is control of the shoulder and biceps. And if there's a lesion there, you usually have no wrist or hand control below C6 because of the myotomes. C6 is wrist control, but you'll have no hand control because that's C7, and so on and so on. If you have a lesion at T1, so upper limb control will be remained because the C1 to C8 is responsible for the upper limb. Your fine dexterous control might be slightly affected, T1, but your lower limbs will be completely affected and you won't be able to move them. T1 to T8, you will get something called paraplegia where you can't use both lower limbs, and you'll have poor control of your abdominal muscles, you will lack core stability, and you might also have problems with bladder control. Now, the overall answer is for C1 to C5 and T3 to T12, you'll essentially have upper motor neuron signs, whereas from L1 downwards, you'll have lower motor neuron signs. Why is that? Because at L1, we have the termination of the spinal cord, and we have the cauda equina. So if you cut here, if you have a lesion anywhere down from L1, you will be hitting the cauda equina nerves. So for C1 to C5, it's both upper limbs and lower limbs will have upper motor neuron lesions. So this means muscle weakness, increased tone, and increased reflexes. And if there's damage to spinal nerves, you might also have some lower motor neuron signs as well, if it's close to the spinal nerves themselves. If it's like within the where the synapse with the lower motor neuron nuclei. But in T3 to T12, upper limbs work fine because they're innervated by C1 to T2. However, your lower limbs will have upper motor neuron signs. So this is your muscle weakness, increased tone, spasticity, increased reflexes. T12 to S2, so upper limb is completely normal, and you have lower motor neuron signs if it's L1 downwards. So fasciculations, reduced tone, reduced reflexes. So you can see this is sort of the application of the knowledge. So it's one thing to know the different anatomy, and it's another thing to sort of apply it. So that is it. That's the end of the session there. The video will be made replayable within like 24 hours, so tomorrow you'll be able to rewatch it completely. There'll also be like content so you can see what's where, and so you can skip to your desired part. If you like this, like, comment, subscribe, all that stuff. We'll also be doing a feedback soon so you can see what you liked, what you didn't like. I did move the time to Friday because a lot of you guys are having VS, and I think going from 3 hours of VS straight to another lecture doesn't make much sense. I'm also well aware that a lot of you guys will rewatch this in your own time whenever you feel like. So we'll be asking about live sessions and if it's been good, if it's been helpful for your studies, and so on. But yeah, that's all for that for me. If you have any questions, do ask me now. You can post them in the live chat. You can post them in the comments, or you can just email the society directly. I'll be putting an email out for that later on. But yeah, if there's any questions, please do ask. I know I went through over a lot of things quite quickly, so if there was something that you missed or need explaining again, then let me know. Okay, no questions. I mean, if anything comes up to you guys, you can just email me on here. So it's gonna be 2233066T, and it's just the Glasgow uni. That's just Glasgow uni afterwards. In the future, we're thinking of making videos for just doing like short videos for questions, because I can appreciate that 48 minutes is quite long for all of you guys. So let us know if that's something you'd be interested in. And yeah, if there's any other questions, just do ask. I'm trying to help as much as I can. If not, then have a nice day, guys. Thanks for tuning on Friday at 5. Have a lovely weekend, and good luck with your studies.